Good evening, everybody who's able to join. Again, my name is Patrick Horne. I'm a nurse practitioner at the University of Florida, UF Health in Gainesville. I'm also a member of the GAP Board of Trustees. So thanks again for joining tonight for our GAP MASLD-NASH Community Network talk tonight, which is going to be on MASLD pharmacology. If you haven't done so already, this is a QR code you can scan to go ahead and register for the meeting. I can leave this up for just a second. And then if you'd also like to get some more disease state education from Madrigal, you can scan this QR code, which will take you to the GAP MASLD-NASH Community Network page. And on there, there is some information from Madrigal, again, disease state awareness, as well as some Madrigal Resmetirom promotional programming. All right, so we're going to dive on into it. The first thing we want to talk about is what is currently available for the treatment of dysmetabolic management. So we're going to break this down into sort of three pie pieces, if you will. So we're going to start on the left in the blue, which is weight loss. So the backbone of any therapy for MASLD-NASH, no matter whether a medication or not, still involves lifestyle modification. So diet, exercise. The recommendations right now from the current societies is the Mediterranean diet, and then the recommended physical activity or exercise guidelines is at least 5 days per week, at least 30 minutes per day. So you're looking at basically around 150 minutes per week of exercise is what is recommended as the ideal amount of exercise minimum to help with weight loss. But we know in addition to lifestyle modifications, we do have therapies available. We have surgical options such as bariatric surgery. They've been around for a while. But more recently, we've seen more of an development of weight loss medication. There's some older medications that have been out for a very long time, but most recently, I'm sure you've heard, around all the data around the GLP-1s. So the GLP-1 receptor agonists, and we're going to dive into those a little bit deeper in the next slide. But within the weight loss category, obesity control category, we've got lifestyle modification, and then we've also got weight loss therapies, including bariatric surgery, as well as medications. Shifting over to the right in the gray, we also need to talk about reducing cardiovascular risk. So that means treating diabetes, which may involve a GLP-1 receptor agonist as well, but there are several other diabetic therapies out there, as you're probably aware. And then we also need to reduce cardiovascular risk. So that means treating things like hypertension, as well as dyslipidemia, in addition to possibly diabetes if the patient has it. And then third part of the pie is actually specifically targeting MASH or NASH, as it says on the slide. And that's with liver-directed therapies. And so we're going to talk about vitamin E, we're going to talk about Pioglitazone, and then we're also going to talk about Resmetirom. So first, let's talk about the GLP-1 receptor agonists, or RAs. So you may or may not be aware, GLP-1 is actually naturally occurring in the body. So after you ingest food, the endogenous GLP-1 does multiple things that maintain blood sugars and assist with weight management. So endogenous GLP-1 stimulates glucose-dependent insulin secretion. It suppresses glucagon. It does delay gastric emptying, so it gives you that feeling of fullness. And then it also acts on the hypothalamus for the same reason, to promote satiety and reduce energy intake. So what the receptor agonists are doing, they're an analog of this already naturally occurring gut-derived incretin hormone, GLP-1, or glucagon-like peptide 1. And so the GLP-1 receptor agonists, they lower blood sugar and they cause weight loss by increasing the effectiveness of all the things that we mentioned above. So what is the role of the GLP-1s in hepatology practice? So semaglutide is probably one of the more commonly known ones. This is data from their late-breaking abstract that was presented as an oral presentation at the liver meeting back in November. So at the 2.4 milligram once weekly dose, which is the highest dose, they saw that the drug met both of the primary histological endpoints set out by the FDA at 72 weeks of therapy. What that means is the two endpoints were, we saw MASH resolution without worsening of fibrosis, and you can see that was at a rate of about 28.9% compared to placebo. And then they also met the endpoint that there was significant improvement in liver fibrosis by at least one stage or more without worsening of NASH, and that occurred about 14.4% compared to placebo. So the takeaway from this presentation that the authors wanted to make was that GLP-1 should be considered for patients who are overweight and have MASLD, and a higher priority should be given to those with MASH and or fibrosis. They were not recommending the use of GLP-1s in patients with lean MASH because, again, in those patients, obesity is not the main driving factor of their MASH. So GLP-1s are great, but we do have some things that we need to take into account when we're either prescribing them or if we're seeing patients who are on them and started by someone else. They delay gastric emptying. We just went over that. So with that, though, comes an increased risk of aspiration during anesthesia. So if we're talking about a patient coming in for an upper endoscopy or a colonoscopy or something like that, they need to hold their dose for more than 7 days prior to the procedure to minimize that increased risk during anesthesia. Otherwise, if they haven't, it's now recommended that the procedure be canceled until they have. So vitamin E. Vitamin E was a big hot topic back in 2010 when data came out of the PIVN study. You can see here, it was the dosing was 800 international units per day. And it was indicated in patients who were non-diabetic MASH patients who did not have cirrhosis. So MASH patients, non-diabetic, no cirrhosis. And in the PIVNS trial, what they found is that patients, these patients who received vitamin E actually had histological improvement on liver biopsy. About 43% showed histological improvement when comparing baseline liver biopsy to post-treatment biopsy. The limitations were, it was 43%, which is high, but that also means that 57% of patients did not respond, and it's not recommended for use in patients who have hypertension or who have diabetes. And as we know, a large proportion of our MASH patients have one or both of these comorbidities. The current AASLD guidelines from 2023 do say that vitamin E can be considered in non-diabetic, non-cirrhotic MASH patients. However, the EASL guidelines, which came out last year in 2024, do not recommend the use of vitamin E due to the limited efficacy on both fibrosis as well as the potential risks in patients we just talked about, those that are hypertensive, those that are cirrhotic, and those that have diabetes. Some of the potential risks, there is an increased risk of bleeding. There is some data to suggest that vitamin E may increase the risk of prostate cancer in males. And so it warrants very cautious consideration on which patients you may or may not put on vitamin E. And it's a discussion you need to have with that patient, especially if you're talking about long-term use. Pioglitazone, well-known diabetic medication, has been around. Dose is typically 30 to 45 milligrams per day. There is an indication, not FDA approved, but there is some data supporting an indication for patients with MASH, both with and without type 2 diabetes, obviously. This also came out of the PIVNS trial. Now, the important thing to note about pioglitazone in the PIVNS trial is it did not show benefit histologically over placebo. However, it does show significant did show significant benefits related to reducing cardiovascular risk, which was one of the secondary endpoints. So while it didn't show improvement histologically, it did show improvement in terms of reducing cardiovascular risk, which we know cardiovascular risk is an underlying risk factor for MASLD and the progression to MASH and the development of fibrosis. With pioglitazone, there are some safety concerns. Downside is it can cause weight gain, which is not ideal in this population, obviously. There is possibility of edema. There's an increased risk of bone fractures, especially in women. There's also been a possible association with an increased risk in bladder cancer. So again, just like with vitamin E, this is something that you need to have an individual conversation with your particular patient about whether or not this may or may not be the right drug for them. And Resmetirom. So Resmetirom was approved just over a year ago, March 14th of 2014. It is currently the only FDA-approved therapy specifically for MASH. It was approved in conjunction with diet and exercise. As I mentioned on that earlier slide, diet and exercise are still the backbone of any MASH management, MASH therapy, no matter what you're using. And it is approved for non-cirrhotic MASH or NASH patients with moderate to advanced fibrosis. So that means stage F2 to F3 fibrosis. So not approved for mild or early stage, not approved for cirrhosis, but approved for that at-risk NASH population or stage 2 to stage 3. It's a thyroid hormone receptor beta agonist, and it selectively binds to and activates the thyroid hormone receptor beta receptor within the liver. So it only acts within the liver. So it is a liver-directed therapy. And this is sort of the pathophysiology and relationship between the thyroid and the liver. I'm not going to go into this in detail just for the sake of time, but I wanted you to have this accessible. So the MAESTRO-NASH trial, this is a phase 3 randomized controlled trial. This was the trial that led to the conditional approval of Resmetirom. It is an ongoing trial, so we're still getting data out of this. I believe they just released year 3 data. The conditional approval was based on 52 weeks of data, so about a year. But it was a biopsy-confirmed NASH at that time, now MASH trial, and it did look at fibrosis stages F1B, as well as F2 and F3. There were 966 total patients that were randomized, and they were randomized 1 to 1 to 1. So that is 2 different doses of resmetirom, either randomized to 80 milligrams or 100, as well as possibly placebo. And as I mentioned in the earlier slides, the 2 primary endpoints per the FDA are MASH or NASH resolution, which includes a reduction of the NAFLD activity score by greater than or equal to 2 points with no worsening of fibrosis, or an improvement, meaning reduction in fibrosis by at least 1 stage with no worsening of the NAS, the NAFLD activity score. So this is their safety data. So overall, fairly safe drug. They did see increased incidence of diarrhea and nausea compared to placebo, but you can see even both 80 and 100 milligram doses, the increased incidence compared to placebo was minimal. More importantly, there was no serious adverse events or no higher rate of serious adverse events compared to placebo. And this was their primary endpoints. So both the 80 and the 100 milligram dose were shown to be superior to placebo in both categories, actually. So MASH resolution with no worsening of fibrosis. And you can see there the 80 milligram dose was around 26%, up to 30% with the 100 milligram dose. And that's compared to less than 10% of placebo. And then also it was superior when it came to fibrosis improvement by at least 1 stage. And that's basically around 25% for both the 80 and the 100 milligram dose compared to under 15% for the placebo group. So these both did meet statistical significance. So what are our practical considerations when we're managing MASH patients with resmetirom? Well, we want to figure out what is the ideal patients for treatment. So these are going to be adults, 18 or above, with non-cirrhotic MASH. As I mentioned, this is not a drug that is currently approved in cirrhotics. And it's specifically approved for moderate to advanced or at-risk MASH. So that's stages 2 to 3 fibrosis. And again, approved in conjunction with diet and exercise. I don't think we can hammer that home enough that no matter what drug you're putting somebody on, diet and exercise are still going to be the backbone with any therapy. There are some potential drug-drug interactions for you to be aware of with resmetirom. We'll start on the left. A lot of these are antiretrovirals, some currently in used with HIV therapy, some not so much anymore. But these are medications that do need to be avoided. From a liver perspective, things, the main ones to be cognizant of, gemfibrozil, cyclosporin, which we sometimes see in our post-liver transplant patients or post-transplant patients in general, voxilaprevir, which is part of one of the HCV regimens, and then clarithromycin as well, which is an antibiotic. In the middle, drugs that can be used with resmetirom but require a dose reduction of the resmetirom, clopidogrel, so Plavix, and triamterene. Trimethoprim antibiotic. Again, two of the big ones. The one in the middle is the generic name for Exjade, which is sometimes used in iron overload. So may or may not see that. But clopidogrel is a big one, especially in this patient population, as well as you might see trimethoprim, obviously, with Septra. And then to the far right, medications that are at risk of you having an increased exposure of that medication due to resmetirom. So there's pioglitazone, rosiglitazone in the same class is also in there, montelukast. And then the statins can be used safely, but there are maximum doses that are allowed, and you can see them listed here for the four main ones: pravastatin, simvastatin, atorvastatin, and rovastatin. So things to be aware of, things to be cognizant of if you're going to be prescribing resmetirom for a patient. You need to look at their other drugs and see if there's any potential interactions. So some more practical considerations when managing MASH patients who are on resmetirom. Duration of treatment and monitoring. So this is an ongoing evaluation. We're continuing to get more data from the MAESTRO-NASH trial. As I mentioned, the data so far is out to 3 years. Currently, the guidelines recommend reassessing for response, mainly looking at restaging of fibrosis at 1 year of treatment. That may change as we get more data. The data that has been presented most recently at EASL, the European meeting in May, shows that non-invasive testing, or NITs, do seem to continue to improve over time out to 3 years. So that's very encouraging. We don't have histological data out to 3 years yet. I believe the trial will re-biopsy patients at 5 years at the end of the trial, but we are seeing continued improvements in NITs going out to 3 years on therapy now. But right now, the current guidelines recommend to reassess response using NITs after 1 year of therapy. That can be VCTE, such as FibroScan. That can be MRI, PDFF, CAP, also from FibroScan, other things like ELF, FIB4, etc. Again, there is a panel that is working on the right cut points and how often testing needs to be done. But right now, the recommendation is repeat the NITs after 1 year of therapy. So the questions that remain. So with any drug, right, insurance coverage always drives everything. So widespread resmetirom use will depend on insurance coverage. I can tell you from my personal experience, I've had pretty good success with insurance, and I've heard that from some of my colleagues from around the country. So I don't think insurance coverage has been too big of a barrier, probably better than we've seen with some other drugs for other things in the past. Again, how often are we going to be restaging and getting labs on these patients? That's still under sort of evaluation. What is the duration of these therapies? What are the recommendations? Is this a lifelong therapy? Is this a 3-year, 5-year, 1 year therapy? That we don't really know yet. We're still trying to get answers to those questions. And then we know that there are multiple agents in clinical trials, phase 2, phase 3, that will be coming in the near future. So there's possibly going to be a significant, there's going to be a lot more options potentially, and we may end up seeing combination therapies depending on mechanism of action, data, et cetera. And with that, I will open it up to any questions if there are any.